All right, well, welcome everybody to our November Lunch and Learn, more than just watching hands, more than just washing hands, OCD in children and adolescents. My name is Olga Marable. I'm the Director of Outreach for Fusion Academy. For those who are not familiar with Fusion, we are a private school, 6th through 12th grade, specializing in one-to-one education, offering full-time, part-time, and tutoring school options. We have 7 locations in the DMV, all the way from Virginia, DC, and Maryland options. I want to go over some quick housekeeping before we begin the presentation. So first of all, we are recording our presentation today. I am going to post it to our YouTube page, and I will share it with everybody when this ends. For those who registered and were not able to attend, they will receive a copy of the recording as well as everybody who is on today. If you do not want to be recorded though, I definitely understand. Please feel free to turn off your camera. Please do keep yourself muted throughout the presentation, so that way we are not distracting the speaker. I also ask that you rename yourself on your Zoom if it's not already your first and last name, so that way when we get to Q&A and you have a question, it's easier to address you. The chat, it will stay open throughout the entire presentation. I'm going to keep it open. You guys are welcome to collaborate and network throughout the chat, exchange information, ask questions, provide resources. So you can definitely continue to utilize that. You're also welcome to private chat me if you want to send something directly to me. The speaker will not be moderating the chat throughout the presentation, but if you do ask questions, I'm going to hold on to them until we get to the Q&A at the end. When you do ask questions, please make sure that they are appropriate and not too personal, because we have a lot of people joining us today and we are sharing this with the rest of the nation when we go on YouTube. So I want to do a little quick icebreaker before we get into the presentation. I want to know who's here. I want you guys to network amongst one another. I also want to get to know you guys a little bit better. Please in the chat, utilize it to put your name, the company you are with, and your title, your contact information, website links if you want, and the fun part. We'll stay on the topic of pies, but not pizza pies. I want to know what your favorite pie is that you are looking forward to for Thanksgiving. So mine, I just put in the chat. Mine is pumpkin pie, but it has to be homemade. It has to be with homemade whipped cream, not like the canned stuff, not Cool Whip. But the pie has to have whipped cream or I won't eat it. So that is my pie. Apple pie, Martha, you know, that's a second favorite, but also if I'm doing apple pie, it has to have vanilla ice cream. Clearly I'm a picky eater. Candace, pumpkin pie, thank you. Hey, Robin, pumpkin cheesecake. That sounds really good. Claudia, welcome. Apple pie, yes. Martha, vanilla on top, thank you. It has to have the ice cream. It's just not the same. Hey, Jacqueline, sweet potato. If you have a good recipe, you have to send me it, Jacqueline, because I've never had a good sweet potato pie. Erica, welcome. Apple pie. Allison, pumpkin. Yes. Cherry pie. That's a good one. Welcome, Margaret. Apple with cranberries. Eleanor. Oh, that sounds really good. Oh my gosh, thanks for sharing all these pies, you guys. Dr. Bamba, okay, homemade vegan coconut pumpkin pie. Okay, so these are amazing. I'm gonna say if anybody wants to email me recipes along with the recording, I will include pie recipes for all of us to have. Thanks for sharing all of these, you guys. So today's speaker is Dr. Christina Brooks. She has an extensive experience in cognitive behavioral therapy, exposure and response prevention, parent management training, mindfulness-based stress reduction for teens from work at the Children's National Medical Center, Kennedy Krieger Institute, Johns Hopkins University, and the Center for Anxiety and Behavior Change. Dr. Brooks is dedicated to maintaining knowledge about state-of-the-art treatments for anxiety disorders and OCD and providing training to other professionals. She's committed to community involvement to raise awareness about anxiety disorders and OCD in children and adolescents and ways to reduce suffering from these often debilitating disorders. Without further ado, I will pass it over to Dr. Brooks.
Thank you, Olga. Thank you so much for having me today. I'm super happy to be here and thrilled about the turnout. I'm so happy that other people are interested in this topic. I guess just a little brief intro about the center. So I started the center back in April of 2020, right as the pandemic hit. So that was really great timing. But I did so because I have a colleague who was in Frederick. We're located in Southern Frederick County. And she was just saying how much of a need, like she was telling me for years, how much of a need there was in the Frederick area for more evidence-based CBT practitioners. And I live in the Frederick area. And so living here, I also heard from a lot of members in the community about how there was just so much more need for more providers. And so I opened up in April of 2020, and while I recognized that there was a great need in this area, as there is, all over the nation, especially now, in the world, really, I really underestimated the need within our community. And so I opened the center hoping to build and expand and add other associates on to help provide this quality treatment for OCD, but also, the range of behavioral disorders, mental health disorders in children, adolescents, adults. But currently it's still just me providing these services. And so the need is really overwhelming. So if you know anybody who's interested in joining an amazing team and working side by side, please feel free to reach out, because we are looking for more people to help meet the needs of the community. So like Olga mentioned in the introduction, I am very passionate about teaching about OCD and providing exposure and response prevention therapy for OCD. I'm really happy to be here because I'm hoping that I can provide information about OCD today that helps parents and clinicians and academic staff walk away with more confidence in being able to identify OCD in their children and in adolescents. I also hope that being able to identify OCD early will also open up the opportunity to receive the treatment that we know works, so that it's reducing suffering and preventing the debilitating effects of this disorder. So OCD is a medical condition in which individuals experience intrusive thoughts. And these intrusive thoughts have lots of different content area. It can be about harm, it can be about aggression, sex and sexuality, and yes, also contamination. They do cause a great deal of distress, these intrusive and unwanted thoughts. So people who have OCD do not want to act on these thoughts. In fact, they find them to be really repulsive and disturbing and are diametrically opposed to their value system. So individuals will go to great lengths to get rid of them. The intrusive thoughts are not hallucinations and they're not delusions. And people who have OCD don't enjoy their compulsions. They're incredibly disruptive to daily life, and they cannot simply just stop the compulsions. But with the help of ERP, and sometimes through medication too, oftentimes through medication too, OCD is really effectively treated. OCD is a chronic disorder, so it typically occurs throughout a person's life. So there technically is no cure. Although ERP and or medication, combination of the two, can be really helpful in providing relief for these individuals, it is often the case that their symptoms wax and wane over time. And that symptom severity is largely dependent on the stressors in an individual's life. So both internal stressors and external stressors. So internal stressors being hormonal changes or fluctuations or even changes in biophysiology. And then the external stressors, of course, are things like life changes and transitions, adverse events, and even traumatic incidences. OCD is largely genetic, especially when it presents in childhood. So it's estimated that about 40% of children who have OCD also have one or both parents who also have OCD. And we know that biology and learning are also known causes of OCD. So I mentioned before that genetics play a large role in causing or the development of OCD, especially in childhood. But biology also plays a large role too. So the brains of children who have OCD work really differently in the way that they process neurotransmitters. Some neurotransmitters we know of that are different in their processing is serotonin and glutamate. And there's also parts of the brain structures that are overactive and that kind of erroneously process information in those parts of the brain. So children who have OCD, their brains overreact to uncertainty, and they also don't get the satisfaction from completing things the way that somebody without OCD would. So because the disorder is largely biologically based, medication does play an important role in treatment. However, because there is a large learning component associated with OCD, medication is often insufficient in and of itself to treat OCD because it doesn't address that learned aspect of it. So the way that OCD is learned is kind of goes like this. So generally there's a trigger for it. So like a child hearing about a disease or an illness, and then the child does something that, anybody would typically do. Wash their hands or seek reassurance from someone, or even, tell their family and friends to wash their hands as well. So if a child doesn't have OCD, they're okay and they can move on pretty quickly. But for a child that does have OCD, and when these biological vulnerabilities are active at the time, it's the beginning of a child's compulsions. So they're trying to become certain that they won't get sick or they won't get someone else sick. But because that part of the brain isn't working well and they're not able to achieve that certainty, they continue to engage in those behaviors. And because their brains are much more difficult to signal satisfaction, then they're much more likely to engage in the behaviors repetitively. So essentially, they're learning to respond in repetitive ways to the intrusive thoughts. And these behaviors become deeply ingrained. OCD is one of the most common childhood disorders. And it presents at one of two times, or sometimes both times in childhood. Like I mentioned before, it is largely misunderstood, and it can, because of that, can go unrecognized for years. So some studies have shown that it takes about 2.5 years before a child sees a mental health professional for OCD-related concerns, and that it takes about 14 to 17 years before an individual receives the proper treatment for OCD. And the unfortunate part of it is that the proper treatment for OCD, or the effective treatment for OCD, which is ERP and or medication, is largely very, very effective. We know that about 70% of people who have OCD will benefit from either one of these treatments or a combination of both of those treatments. And I'm really passionate about this because I see children all the time. I see adults all the time who come into treatment after having therapy for a while, or even never having therapy before, and not understanding that this is what they are faced with until much later in their lives when their symptoms become so debilitating. So we can think of OCD as a two-part problem. The first part being the obsession, so the intrusive and unwanted thoughts that cause an individual distress, and then compulsions, which are the repetitive behaviors or mental processes that function to reduce the distress or get rid of the thoughts. I mentioned before that there's many different content areas for obsessions. And the different content areas are commonly referred to as subtypes of OCD. So I have a lot of resources at the end of my presentation that I'll give you. And one of those is the IOCDF, the International OCD Foundation. And they do a great job on their website. A lot of the other resources do a really great job of categorizing the content by subtypes. So if you're interested in learning more about that, please check those out. But, we talked about like the most common is contamination. But in addition to intrusive thoughts about contamination, it's also common for children and adolescents to experience intrusive thoughts in other areas as well. Things like terrible things happening. So like a fire starting or a burglary or storms. It's also common for children to have intrusive thoughts related to harm, aggression, or sex or sexuality. One thing that I can't emphasize enough about obsessions and the content is that children who have these intrusive and unwanted, aggressive and sexual thoughts, they find them very disturbing. They don't want them, and they have no intentions whatsoever of acting on them. So these children are different than those children who might present with signs of disorder such as conduct disorder, because they don't want to harm anyone. And like I've mentioned before, in fact, these intrusive thoughts are diametrically opposed to their core values, everything that they believe in, and they find the thoughts to be incredibly repulsive. But because these content areas are oftentimes really hard to talk about, and the first time that children are really experiencing these intrusive thoughts in these content areas, it can be difficult for them to disclose them. And so it can also then be very likely that children carry around and adolescents carry around a lot of shame associated with these intrusive thoughts. It can also be really hard for parents and teachers and counselors to talk about the content of these thoughts. And so we kind of tend to avoid talking about it or even asking about it. And we might shut down or avoid conversations when children try to bring it up. But it's really helpful to assess for the symptoms. And when a child does disclose these symptoms to you, to respond to them in a very matter-of-fact way that's non-emotional, as if you've heard this 100,000 times before. And what that sort of response does is it sets the stage for modeling a really non-alarming response to the intrusive thoughts, which we'll talk about in a little bit, but is a really important part of the treatment process. So the second part of the problem are the compulsions. And these are the repetitive behaviors and mental processes that a child, adolescent engages in order to get rid of the thoughts or in order to get rid of this distress associated with the thoughts. So typically the distress that's caused by obsessions are emotions like fear and guilt, and they're also associated with uncertainty. So uncertainty about whether or not they're going to be sick, or whether or not these thoughts mean that they're actually going to act on them, or uncertainty about whether or not they'll ever achieve satisfaction and be able to move on. So the function of the compulsions is to gain certainty. So kids with OCD will do things like wash their hands several times to gain certainty that there's no germs left on them, or to get rid of the feeling that is on their hands that makes them feel dirty. So not really, the concern about getting sick or germs, but the concern about the feeling on their hands. They'll wash their hands until they can get that just right feeling. Or children with intrusive sexual thoughts or intrusive harm thoughts may say a prayer for those thoughts that they just had to get rid of the guilt and to make sure that they're certain that they're being forgiven or that they're not doing anything wrong by having those thoughts. And the compulsions do provide some immediate relief for kids and adolescents, which is why they continue to engage in them. But they don't provide the long-term satisfaction and certainty due to those underlying biological vulnerabilities. And so that immediate relief that they experience actually negatively reinforces or strengthens the compulsive behaviors so that they're more likely to engage in them in the future. No amount of the compulsions, behavioral, or mental processes is sufficient to signal completion and certainty. And so, like I mentioned before, these behaviors and the mental processes become very deeply ingrained. I love this illustration. It came from OCD Doodles. They have an Instagram page. They're all over social media. But I find it's really helpful in understanding the process of OCD because the content of the obsessions, although they are disturbing, is not the problem. The problem is really the process that occurs. The other part of the problem is really the meaning that's attached to those obsessions that happen. So, for example, the presence of having this thought that I'm going to get sick means that I'm more likely to get sick. Or the presence of this thought, this like intrusive sexual thought, means that I'm more likely to act on this thought. Or the presence of the thought that, that there is going to be a fire in my house means that I am responsible for eliminating all risks associated with it happening. The more a child attributes meaning or value to the thoughts, the more distress that they're going to feel when the thoughts come up or when they encounter a trigger. And then the more compulsions they're going to engage in to reduce that distress. So another goal of ERP is to help a child loosen the association between a thought and the meaning of that thought, which is why it's really important when a child does disclose to us that they're having these thoughts that we respond, no matter what the content of the thoughts is, that we respond to them in a very matter-of-fact and non-emotional way, because we do not want to strengthen that meaning of the thought for them. So what does this look like? I'm going to give some examples, I guess, of like how it presents maybe for a mild case of OCD, for a moderate case of OCD, and then for a severe case of OCD. And of course, I can't present on all of the different content for obsessions, but I'll do my best to cover some of the main ones that I've seen and that I've worked with. So when a child or an adolescent has like mild OCD symptoms, what that means is that they're having the intrusive thoughts or engaging in those compulsions for about an hour a day, at least an hour a day, but it could be up to like 3 hours a day. So for a child who experiences intrusive sexual images or intrusive sexual thoughts, they may have images of genitalia, penises or vaginas or breasts that pop up throughout their day. And they spend at least an hour a day trying to get rid of these thoughts. So they might avoid people or places or things like walking past bathrooms or using the bathroom at school with peers, or avoid eye contact with their teacher. They might also avoid playing with other children or engage in mental compulsions, such as, let's see, like counting or praying, or repeating rituals. So like rereading or rewriting. So oftentimes I'll see kids who have these intrusive thoughts while they're studying or while they're doing their schoolwork, and they will have to erase what they've just written while they've had that thought and go back and rewrite that thing without having the thought in their mind, as a way to like gain certainty that they are not going to act on that thought, that thought isn't going to result in them being more likely to act on that thought, or so that thought, the presence of that thought, doesn't cause like other negative consequences in the future, like failing the paper that they're working on, or having a failing grade on a test. So when a child has mild symptoms of OCD, typically they're able to, move throughout their day and function fairly well. There's impairment in their daily life, but it's minimal. This is a really great point in time, though, to get a child involved in ERP, because the earlier that you can catch it and the earlier that you can have a child start to develop and learn these skills, and we as parents can understand it, then the more likely it is in the future that we can prevent the suffering or the more moderate or severe impairment that comes with OCD. So a moderate severity of OCD is usually about when a child, or adolescent is having intrusive thoughts at least like 3 to 8 hours a day. And they're also spending that amount of time engaging in compulsions. So for example, for a child who has just right OCD or an obsession about making sure that things feel okay or things feel right, either, morally, or most often with just right OCD, it's like more of a sensation, like that satisfaction sensation. They will redo their hair, or they'll change their outfit a number of times. They'll walk through the same door multiple times. They'll reread and rewrite. They'll even a lot of times rethink things if they feel like they haven't thought it right the first time. They'll pick up and put down their backpacks in just the right way. They'll even have a mental compulsion where they're arranging things in a room in their minds so that they look just right. So when these intrusive thoughts and these mental compulsions are happening at this rate, they're really taking up a lot of attention. They're really taking up a lot of time too. And so kids will look very distracted in the classroom. They'll look very distracted at home. They'll look like they're lost in thought. It'll also take away from their ability then to focus and concentrate on class. So they'll fall behind on the lessons, or it'll take them much more time to complete their work than their peers. And it also might make them more likely to take more time in responding to a question that is asked, or providing an answer to a question, because they are trying to, formulate that just right answer, or they're trying to hear the question that was asked in just the right way. At this level, we also see quite a bit of irritability and tantrums and outbursts if a child is not able to engage in their compulsions, or if their parents or caregivers or teachers or friends aren't engaging in the compulsions that they often involve them in. On the severe end of things, this is where kids and adolescents are spending more than 8 hours a day engaging in their compulsions, and more than 8 hours a day thinking about their obsessions or having the intrusive thoughts. For kids who have severe OCD, there's often more than one obsession that they experience. So, maybe it's in, the intrusive thoughts of a fire or a burglary, but it's also then intrusive thoughts of spreading illness or intrusive thoughts of harm, and intrusive sexual thoughts as well. And so these children may have significant difficulties attending school. If contamination fears are one of their obsessions, then they might be very fearful that there are contaminants at school that are going to get them sick. Or if their obsession is, kind of fear of spreading illness, they might be very concerned about going to school and bringing home illnesses. And so they might insist that their parents homeschool them, or that they, stay home from school. They might have trouble getting started on or completing work because of maybe intrusive thoughts of harming themselves. Maybe like if they pick up a pencil, they might have the intrusive thought that I'm going to stab myself with this pencil or this pen. They might avoid utensils to eat. They might insist that their parents cut up their food for them. If they, are at an age where it's developmentally typical for them to be cutting up their own food, they might insist that their parents cook their food. They might insist that their parents cut up their food. They might also insist that their parents avoid using the stove or the oven, or lighting candles in the house. I've often seen kids who have very severe OCD contain themselves to one room in the house, and one spot in that room in the house, or to insist that they don't go certain places, that their parents don't go certain places, that their parents engage in rituals like taking off their shoes and wiping their shoes down before they come into the house, and wiping the floor up after where they walk, even if they're not wearing shoes, or having their parents wipe down all of the surfaces in their house before the child can use the surface of the house. So, I guess the important thing here that I want to mention is that even for mild, moderate, and severe levels of OCD, kids involve their parents quite a lot in their rituals and their compulsions. And so this is a really important part of treatment to address. Sorry. With OCD, comorbidity is the rule and it's not the exception. So as you can see from some of the previous examples, OCD can be mistaken as lots of different things. The inattention that kids have when they're in school can be mistaken for ADHD and attentive type. OCD can also often be mistaken for social anxiety disorder. If kids are avoiding their peers because of fears of contamination or because of intrusive sexual or harm thoughts, then on the outside and at first, before you really understand it, it can look like social anxiety disorder, avoiding those social situations because they're afraid of those perceived, negative perceptions of others. It can also be mistaken as generalized anxiety disorder. For individuals, children and adolescents who have OCD where their compulsions are mainly mental compulsions, oftentimes it looks like they are like those GAD kids, like the worriers. So it really takes careful assessment to understand and to uncover some of those mental compulsions that they might be engaging in. So we know that ERP works really well, and these are the gold standard treatments. We also have found through, over time in doing ERP and through the third wave of CBT that ACT, or acceptance and commitment therapy, works really well as an enhancer for exposure and response prevention therapy. And then I've mentioned several times medication. So ERP is our two-part solution to OCD's two-part problem. And it consists of both exposure and response prevention. Exposure being where we are creating a plan with children and their parents to gradually increase direct contact with triggers, and response prevention being where we are gradually working to reduce compulsions. And we do this by helping children and their parents develop more flexible ways of responding to distress as we kind of let that distress run its course. One of the keys with response prevention is that time is the most effective thing that allows distress to pass. It's the most effective way that we can address the distress. It is known as the great equalizer. And for response prevention, exposure and response prevention, it's really a key component of it. I want to help kids and their parents understand that the distress that happens from the obsessions is temporary. It is unpleasant, absolutely, and it's temporary. And there's nothing but time that's going to help to allow that distress to run its course. So some examples of ERP, if a child is experiencing those intrusive thoughts that something terrible is going to happen, like a fire, we might have the child and the parent use the stove to help make dinner while delaying the time after using the stove that the child wants to check to make sure that the stove has been turned off. Or we might also help to limit the number of times that the stove can be checked. Or we might help the parent develop a statement to give to the child instead of providing the child with reassurance. So instead of saying, yes, yeah, absolutely, we turn the stove off, we can help the parent understand to say things like, I love you too much to answer that question. Another example is, if we have a child who has intrusive harm thoughts, we might do ERP by having the child use knives or use scissors, use that pencil, use that pen, and again, limit that reassurance seeking. And we might even teach the child to use some grounding strategies, which are mindfulness strategies and mindfulness skills to refocus on the present moment. So as a way to allow time to pass for the distress to pass. We would not be encouraging a child to engage in the grounding strategy to get rid of the distress, because that would just perpetuate the compulsions and the OCD cycle. An example of how we might use the ERP to address the intrusive sexual thoughts and compulsions or avoidance associated with those is we might have a child sit close to family members. We might have a child hug family members. We might have a child or an adolescent help with routines such as changing a baby's diaper or playing a game with children who maybe are relatives, or spending time at places like a park or a mall or a playground where children are likely to be present. And then we would use some of those same response prevention strategies to help prevent some of those mental compulsions or behavioral rituals or compulsions. So like I've mentioned, the response prevention, there's a huge part of parent involvement that is necessary for it to be effective. And we also have to include teachers in helping to understand OCD and help to be a part of the plan in ERP at school as well. Through ERP, kids are learning how to effectively and flexibly tolerate the distress that they experience. They're also learning that although the content of their thoughts is disturbing, that they are just thoughts, and they're kind of like sheep in wolves' clothing. Um, Although they're really unpleasant, they're harmless. When we're doing ERP, our goal is always 100% response prevention. So we want to get rid of all of those compulsions. And our goal for outcome and symptom reduction is 50% of reduction in symptoms. Our research has found that with that amount of reduction in symptoms, typically kids and adolescents are able to resume their typical and normal functioning in their lives without OCD causing interference. The third wave of CBT is acceptance and commitment therapy. And ACT alone is typically not used to treat OCD, but it is used to enhance the ERP process. So it can do that by helping to motivate people towards change. ERP is really hard work, and it requires a willingness to experience distress. So for both parents and kids, where their distress tolerance might be really low, it might be really tough for them to want to engage in this process. So it can be really helpful to focus on values for both when you're working with both parents and children, and having children and their parents understand their why and recognize their goals. It's a really important process in facilitating compliance with the treatment plan. Parents and children are going to have to do a lot of ERP work outside of the therapy setting. And so again, having them recognize their values and why they're doing this can be kind of like the backbone to treatment, or the part of the foundation to treatment. ACT also supports ERP because it helps to increase that cognitive flexibility and distress tolerance. So ACT infuses a lot of mindfulness practices to help children be present and experience distress from a non-judgmental perspective, to really open up around and accept that unpleasant emotions and sensations and thoughts are a normal part of the human experience. And then it helps to develop flexible ways of responding to those unpleasant experiences through mindful and committed action. SSRIs, or selective serotonin reuptake inhibitors, are the first line treatment for medication for OCD. Luvox, Zoloft, Celexa, Lexapro, Prozac, and Paxil. Those are all SSRIs that are typically used to treat OCD, but also tricyclic antidepressants such as clomipramine can also be helpful. And then serotonin and norepinephrine reuptake inhibitors like Effexor can also be helpful. There are a lot of times where maybe children who have OCD and who also have an autism spectrum disorder, or adolescents who might have an autism spectrum disorder, or adolescents who have very severe OCD, might benefit from an atypical antipsychotic as a part of their treatment plan, because it really does help to increase that cognitive flexibility when the thought process is really inflexible. a lot of times parents will ask, well, can I just go to my pediatrician to get the medication? And what I recommend for OCD is that they typically work with a psychiatrist or a psychiatric nurse practitioner to come up with a medication treatment plan that's going to nicely enhance and supplement the ERP that we're working on. When I talk with pediatricians about OCD, a lot of times they are more hesitant in prescribing medications for OCD. And I think it's similar to like going to an orthopedist for, a broken bone in your hand. You wouldn't necessarily go to an infectious disease doctor for that. And so we want to get people to the right treatment and to the individuals who are going to be best equipped to help them. So how can parents help? Number one is they can help by seeking to understand a child's OCD and their symptoms without judgment. Really having that non-emotional and matter-of-fact response to their symptoms is so, so important. From there, they can then better recognize how their responses to their child's symptoms maybe actually unintentionally reinforcing the cycle. And so we can then identify those accommodations that they're providing that are doing that, and we can work together to reduce those accommodations, again, in a very gradual way most of the time. It's really important to include the child in that process when they're willing to engage in that process, because we find that when a child has a buy-in in this sort of therapy, that it really helps with the effectiveness of the treatment. So, we might help parents identify, instead of providing reassurance, we might help them identify different responses to a child's reassurance seeking, which is like one of the number one compulsions that children with OCD engage in. Once they have a piece of information, it's not enough. And so they have to ask the same questions over and over again from their parents and oftentimes from their teachers too. And so we can help parents to identify statements like the one I mentioned before, like, I love you too much to answer that, or something like, is that you asking or is that OCD asking? Or sometimes even like inserting some humor into a response. So if, excuse me, a child is really scared that and having intrusive thoughts that maybe there's a burglar in the house, or that they didn't lock the doors, or that they didn't check under their bed well enough, they might say, hey mom, hey dad, could you please check under my bed? And so maybe, as a parent, you can respond by saying, I think there is something under your bed. I think that it is a litter of little beagle puppies ready to jump up on your bed and lick you all over. Or like a common one in our house that we use with our son is, I think it's Aaron Rodgers under the bed, like ready to jump out and play a football game with you. So not answering the child's question, kind of changing the subject, but also inserting some humor into it. Again, to help the child diffuse from those thoughts and to help them see those thoughts from a non-judgmental, more playful perspective. It is so hard to be scared when you're having fun. We can also help to cue our children into when we are noticing that maybe they're engaging in compulsions, and maybe the child isn't so aware of it. And again, agreeing on something that you can say, like, hey, I think I'm noticing some OCD going on here. And then asking, what can I do to help disrupt this cycle? What can I help you do to overcome this OCD in this moment? So along the same lines, and parents can really encourage their children to do the hard work, identifying times in the past where kids have overcome a challenging situation and use that in the moment to encourage similar behavior or similar mindset to doing this incredibly difficult work. positive reinforcement and rewards and coming up with a schedule to help reward a child for their incredibly hard work is also a really helpful part of this process, this treatment process. And similarly, you can do things like have compulsion coupons where, in the beginning where you're working to reduce some of those compulsions in a gradual way, you can, maybe say, let's give the child like 5 reassurance seeking coupons throughout the day. And so once they've used all of those up, they can't ask any more reassurance seeking questions. As a parent, you don't provide the reassurance. They can ask the question, but you still don't provide the reassurance. But the fun part of this, or the rewarding part of this, is that if a child doesn't use all of their coupons, and let's say we set a goal of, if you have 3 left at the end of the day, then you can have a reward. That can be really motivating to help a child reduce the compulsions that, seem are so ingrained in their daily lives. And build awareness around it too. Because when a child does, seek reassurance, and if they're not handing over their coupon, you can say, oh, is that OCD or is that you asking? I'm going to need one of those coupons. I think when a child's OCD or an adolescent's OCD impacts them at school, we can talk to the school personnel. We can do behavior observations in the classroom, or we can schedule meetings to talk with the teacher or the school counselor to really get a good understanding of how the behavior is presenting itself in school and how it's, how it's impairing their academics. And so the therapist can do this. You can, talk with your child's therapist about doing this, or, you can do it yourself as well. So then when these symptoms show up in the school setting, teachers and academic support staff can also help with the treatment process. So again, starting with seeking to understand the symptoms without judgment, and seeking to understand OCD in general and the process of OCD in general. A lot of the supports and accommodations that teachers can provide may be necessary in the beginning, but are also going to need to be reduced throughout the course of the year or throughout the course of the treatment that the child is going through, so that it is not unintentionally contributing to that OCD cycle. So, for example, if a child has contamination fears, it might be helpful at first for a child to have a separate set of books at home or their own set of supplies within the classroom, maybe taking handouts first or scheduling bathroom breaks like during low traffic time. But as the child is moving through treatment, we can include these in the exposure and response prevention plan. And so keeping that communication with the teachers and the communication from teachers to parents consistent is going to be really helpful as we are continuing to move up the hierarchy and the plan. There's some other examples here for just right or repetitive or ritualistic behavior. So if a child's having a lot of difficulty rewriting or rereading, teachers can initially, again, provide class notes or partial class notes, or help to break down larger assignments into smaller, suggest time limits for assignments, provide alternatives for writings, have oral exams, and then to help with response prevention, we can also do the same things that we do at home, and like giving a child limits for the questions that they can ask. And I guess one thing that I didn't highlight before that I meant to is that a lot of times kids with OCD will have a great difficulty making decisions. So if a teacher hands a student, with just right OCD, a list of topics that they can choose from, or a list of books that they can choose from to write a book report, a child might feel incredibly overwhelmed and oftentimes like stuck in making a decision. So limiting the choices that you provide that child, maybe one or two. And then we also build into the ERP strategies for making those decisions, so that the child isn't engaging in that mental ping pong, going back and forth and vacillating, and they can move forward with one decision or another. So it'd be great for the teachers to know what that strategy is too. So that back and forth communication. Um, it can also support response prevention if a child's having a lot of difficulty rechecking their backpacks, having predetermined check times of their backpacks. So let's say you check your backpack in the morning when you first get to school, and that's it. That's the only time throughout the day that you're allowed to check your backpack. You can have the coupons at school too. It might be helpful to have some salient rewards within the school building. And so, I think we often think of, 504 plans and IEPs for children with emotional and behavioral disorders, and OCD is no exception. And a part of the 504 IEP that could be particularly helpful for a student with OCD might be a behavior intervention plan. So working with the school to help them understand what the ERP plan is, and from all of the information that you gather from the school, you guys can work together to develop a behavior intervention plan within the school, such as using the coupons or providing direct reinforcement for engaging in incompatible behaviors other than those compulsions that they want to engage in, and having a reward within the school building to reward the child for all of the hard work they're doing right there in that environment. And similarly, like I talked about before with the parents, just providing that student with a ton of encouragement. So when they hit an obstacle, thinking of times in the past in the classroom or in the school where they've overcome a challenge, and using that as evidence to help encourage them that, hey, this was the last time, or this was something that happened that you persevered through, and you did this. And that was, that resulted in you being able to overcome this obstacle. We can do the same thing here. You can do the same thing here. And even asking the student, what is it that you need from me? A lot of times, and parents can ask that too, what do you need from me? A lot of times kids will say, well, I need you to engage in that compulsion, or I need you to provide me with that reassurance. So that can be tricky. And so it's up to us as parents and adults in these kids' lives to really recognize when those accommodations are not going to be helpful and are actually going to hurt our kids, in terms of, worsening the OCD. And so this kind of brings up a point that I meant to mention before with the slide about how you can help when oftentimes children are reluctant to and resistant to engage in the therapy process, adolescents especially. And so when that's the case, we can definitely do a lot of great work for ERP for the parent, to reduce the accommodations that they're providing and to build their own distress tolerance around their child's distress. Eli Leibowitz, who is at the Yale Child Study Center, developed the SPACE program, which is the supportive parenting for anxious childhood emotions. And it's a program that he designed specifically for parents when children and adolescents are resistant to engaging in therapy. And in conducting research around this program, they found that it has been just as effective as individual ERP for children in addressing OCD symptoms. Put the website for that SPACE treatment here. And if you're a clinician who's interested in being trained in the SPACE treatment, it's a fantastic training, and you can sign up on his website here. There is the International OCD Foundation. I do a ton of work with the IOCDF. We are actually, a group of us are working together to do presentations like this within our communities to mental health providers to help further the understanding of what OCD actually is and what the effective treatment is. I am currently working on developing a training program and offering consultations to other mental health providers in the area and to help further their training. And this work is being done, with the IOCDF as well. Made of Millions is a great resource for both, not so much kids, but adolescents and their parents. It started off as intrusivethoughts.org, and it was directly related to OCD, but it has become such an invaluable resource for information about mental health disorders of all types. There's several books here that I strongly recommend. Most of them are on my website. A few workbooks for teens. There's one here for kids, What to Do When Your Brain Gets Stuck. That's for younger kids. Up and Down the Worry Hill is also for younger kids. And then there's a couple books here for parents as well. I love the podcast, The OCD Stories. If you have not heard of it, check it out. It's amazing. The host interviews psychologists and social workers all throughout the world who specialize in ERP. Some of these providers also are OCD sufferers themselves, and so they speak from both perspectives. And then he also interviews individuals with OCD. Young adults are common guests on the podcast. And so I find that sometimes it's helpful for adolescents who carry a ton of shame around with them for some of these intrusive thoughts to listen to a few of these podcasts to gain a sense of I guess, kinship with other people and knowing that they're not alone in experiencing this. Because shame does breed that isolation, which just breeds more shame. And then there's some additional trainings here too. If you're interested in having more advanced training in ERP and the treatment of OCD. The last resource that I wanted to mention is that I am starting an ERP treatment group for adults. It's virtual. So if you know of any adults who are looking for ERP and maybe are on a few wait lists, but would like more immediate treatment, we're starting that 10-week group November 16th, and it'll be virtual, and it'll be on Tuesdays from 5 to 6:30. I am excited to hear thoughts and to answer any questions as best I can.
Thank you, Dr. Brooks. This was absolutely wonderful. Really great feedback in the chat. Appreciate everything that you had just shared with all of us. And I will start asking some of the questions that came up in the chat, but you guys are welcome to keep asking questions and I'll just go through them in order. The first question is, let me try to word this appropriately. How does OCD determine how somebody reacts to it? So for instance, a person who has to wash their hands multiple times versus somebody who has to count. This one person used an example of counting syllables or zippers in the road while driving, and even waking up at night and counting. How does the brain determine a counter versus a hand washer or what you're counting?
Yeah, that's a good question. So I think the main thing to focus on here is not the behavior itself, because just like the content of the thought doesn't matter so much as it does the way a person interprets that thought or the meaning that they attribute to that thought. It's similar for the behavior. So, it doesn't matter so much that a person is hand washing or checking. It matters what function that behavior is serving. And so if that behavior, when somebody engages in a compulsion, whether it's behavioral or mental, that compulsion is largely functioning to gain certainty in that situation. And so whether it's hand washing or whether it's counting or whether it is, mental checking, what the person is trying to do is gain certainty. And I guess, the compulsions can develop quite naturally. Like I mentioned before, the type of compulsion can oftentimes be logically, and logic is subjective, right? But can be logically linked to the content of the obsession, but sometimes it's not. And so that's why I say it's not really the behavior itself that matters, but it's more understanding what is the function of that behavior. So certainty seeking is definitely the number one function, but the other function of compulsions is to reduce distress and fear and distress of like that incomplete kind of feeling, so think about those two functions instead of focusing so much on what the behavior itself is. Like, what is the purpose that this behavior is serving? Is it to get that complete feeling, or is it to seek certainty?
Thank you for answering that question so wonderfully. The next question, Kyle asked, is it possible to have either or obsession or compulsion?
In order to have a diagnosis of OCD, you have to have both. And keep in mind that the compulsion can be avoidance. So go back to my little OCD doodles, little cycle here. Oh, where'd it go? These are the different compulsions that occur. And so avoidance is considered a compulsion. So in order for somebody to be diagnosed with OCD, yes, they have to have both.
Thank you. Next question, Madeline asked, so the just right type OCD looks like perfectionism. Is that correct?
Yes, it can look like perfectionism. Absolutely. A fear of imperfect outcomes is a common obsession that, like, I'll talk about, people who come to treatment because, they're constantly trying to get that just right feeling. So it might look like they're trying to find the perfect outfit, or they're trying to make their hair look a perfect way. And again, that perfection is in their minds associated with what feels right to them. So it's not necessarily, it looks like perfectionism, and perfectionism is different in that perfectionism is a consistent striving for high achievement and having very inflexible, and that's the key, very inflexible high expectations. Whereas just right OCD, although it can look like perfectionism, is more, I'm trying to get that feeling, like that physical feeling of just right. And it might not necessarily be high aspirations, if that makes sense. But Madeline, that's a really good question.
There's a few really good questions coming in. Thank you so much for answering that. I have 5 more in the queue. Next one is from Stephanie. What would be the youngest age for medication that you would recommend?
Ooh, I think I would have to defer to a psychiatrist for that one. I have worked with kids as young as, as young as 7 on an SSRI. And in that situation, it was very much necessary, and it was related to OCD that popped up as a result of PANDAS. Super severe OCD. One of those times where, a 7-year-old kiddo was really contained to one part of a room of the house. So that's as young as I've worked with that has had an SSRI. But I would say check with your psychiatrist, talk with your pediatrician first, and then with a psychiatrist, and they could probably give you a better answer.
Yeah. All right. And then Beth actually asked, can you work remotely with individuals outside of Maryland?
I can. Yeah. As a psychologist, I have an e-passport through SIPACT, which was legislation that was passed just recently, I believe in June in Maryland, which allows psychologists to have an e-passport to provide services to people outside of the state of Maryland, but they're in a few select states. When I say a few, I mean like 25. So half of the US, which is actually pretty good. So you can check out on the SIPACT website. So it's PSYPACT, which states are involved in that. And those are the states in which I can provide teletherapy to people.
Cool. All right, next question is Erica. What is the earliest indicator of OCD in very young kids?
There are a few. Inflexibility, like behavioral inflexibility. Having difficulty adjusting and adapting to changes in routines. Low distress tolerance. So kids who have difficulty tolerating internal or external distress and react really strongly to it. Anxiety sensitivity is another indicator. So this is kind of when a child has supersensory powers and they experience physiological arousal very easily and very intensely, and goes kind of hand in hand with that distress tolerance. So they have a really hard time tolerating it. Trying to think. Those are some of the early indicators, but a lot of times kids present to treatment and adolescents present to treatment with symptoms of OCD without a lot of this in their past. But those are a few of the early indicators.
Would sensory issues be an early indicator?
It could be. Yeah, it could be. It doesn't necessarily mean that, a child will develop OCD, but it could be an indicator.
All right, next question. Can you speak to how to help these people make decisions? I think you touched briefly, but would like more information. This came from Martha, and she's saying that she has a teen who can tell her everything, but doesn't want to make a decision. But making a decision is nearly impossible. Sorry, hard for me one.
Yeah. So sometimes we'll talk with people and try and kind of reframe the decision process before we do some response prevention around it. So helping people understand that there's no final decision in life ever. Well, there's one final decision, but other than that, most decisions can be changed. And we always have an opportunity to change our minds. And, if it's related to, having that perfect outcome, it's like, we can change our mind. So if we don't like the outcome that's happened, it's a learned experience. We get to learn and we get to use that information to apply to a new decision that we make. But moving, pretty quickly into the response prevention for helping make decisions, a couple of guidelines that could be helpful would be limiting the resources that a person uses to gather information to make a decision. So a lot of times I'll see people who do, if an adolescent is trying to pick out their outfit, let's say for the next day, and they're stuck on, I need to find the one that's going to look the best or look the right, just look the right way. They may, have like 10 outfits, and they may seek reassurance or input from friends and from family members. And then they have information overload, which just makes making that decision that much more difficult. So we can limit the amount of information. So saying like, you can't go to more than 3 people or 3 resources to get information to make a decision. We might also do like a random number generator and say decision 1 is this and decision 2 is this, and go, push the button on the computer and have it randomly generate the number. And then that's the decision that you go with. Or rolling a die, or saying, having some sort of system to that to help take like kind of the guesswork out of the decision making and help them make the decision and move forward with it. So those are a couple ideas that can help with helping somebody move forward with decisions.
Thank you. All right, Claudia asks, can excess discipline, like through cultural superstitions, parenting approach, religion, etc., lead to OCD?
It plays a part in the way that a child learns. It plays a part in the way that a child learns how to respond to these experiences in their life. So it's not a cause per se, but it is a factor that can contribute to their learning around it. And we see this sometimes with scrupulosity or religious themes of OCD, where a child has these biological vulnerabilities to developing OCD, and they have this like fertile soil of, a religion that has that's governed by pretty, strict rules and rituals, and the two of those combined really cultivate a pretty moderate to severe case of OCD where, where somebody without OCD could follow those rules and rituals and routines and it not develop into maladaptive avoidance of actually going to the religious services or engaging in the religious services. But somebody with OCD, those rules, the dogma, the participation in the rituals, the religious rituals can actually contribute to the learning that happens in that OCD cycle and make it a lot worse. And in the content area of religion.
Thank you, Dr. Brox, for answering that. All right, next one. I can see how OCD can be easily misdiagnosed with ADD, with self-distraction. Have you seen it misdiagnosed with executive functioning?
Absolutely. And not necessarily, could be missed, but when somebody has OCD, when a child or an adolescent has OCD, it does impact their executive functioning. So it wouldn't be diagnosed as like an executive functioning disorder per se, it would be diagnosed as OCD. And yeah, I've seen it overlooked quite a bit. But, as you can imagine, if a child or an adolescent, and their internal resources are all taken up by the intrusive thoughts and the mental compulsions, that is certainly going to impact their working memory. It's certainly going to impact their attention. It is certainly going to impact their ability to regulate their emotions and shift from one activity to another. There is actually a strong biological link between ADHD and OCD and Tourette's. So we think that researchers think that the same structures of the brain are involved in all three of those disorders. And those are the three that we see most commonly co-occurring.
Great. And then a second part of that same question from the same person. If someone has OCD with anxiety, which disorder would you treat first? Because I see how the two can be hand in hand.
So can you be more specific about anxiety? Because it's like Baskin Robbins, 31 flavors.
That's a tough one to answer. We'll go to the next one.
Well, I'll answer that one, even I guess without the answer to that question, but it would depend on which is most incapacitating and which one is, causing the most impairment at that point in time. But typically, the gold standard for treating anxiety disorders is CBT with exposure. So you're doing the same treatment for both of those. I think you would, if you see that the compulsions are really taking the primary focus, then we really have to work to reduce those compulsions in order to effectively treat the underlying or the co-occurring anxiety disorder.
Thank you. I know that was a hard one. All right, 6 more minutes. Let me catch the last. I have 3 questions in the queue. Santana asked, could you speak to purely O in the OCD? And I did have clarity on that. There was a training that she attended about purely O for OCD.
Yeah. I wonder if that was training was done by Sally Winston, but she's like one of the people who, she's, local, of course, and she's one of the people who really talks a lot about the role of intrusive thoughts in OCD. So pure O is not actually pure O, because if it were only obsessions, it wouldn't be obsessive compulsive disorder, it would be GAD. Technically speaking. But pure O are intrusive obsessions, and the compulsive part of it is the mental ritualizing. So you can't really see you can't see the behavioral compulsions, but that one of the primary mental rituals that happens with pure O is rumination. So that mental ping pong, trying to figure out or trying to analyze, trying to answer an unanswerable question. So when people talk about I'm spiraling, oftentimes that's like a cue word for me that indicates, okay, there's some mental compulsions going on here. So for example, there's real event OCD, which is a subtype of OCD. And this is like where you have an experience in the past that you are obsessing over, not necessarily a traumatic experience, but an experience that just comes into your mind. And maybe it's a potentially embarrassing situation that happened, or humiliating situation that happened. And excuse me, you're thinking about it, and it pops into your mind at all of these inopportune times. So example, college person who goes out and has a night out on the town and has a ton of fun, and they have some drinks and they have some alcohol. They're intoxicated. They do not black out. They don't have a gray out yet. And they have a good time, and they wake up the next morning super fearful that they've done something embarrassing or humiliating the night before. And so what do we do? Again, what do we do is like a normal, typical somebody, without OCD. We kind of think about it and like retrace our steps in our mind and like, what did we do? What could we have potentially done? But again, because that OCD brain doesn't process that certainty and doesn't give you that feeling of satisfaction, this person is going to continue to mentally review the events of that night in order to try and gain certainty that they did not do anything that was humiliating or embarrassing. Or they might try to analyze different behaviors that they had throughout the night or people's reactions throughout the night. So it's all of this mental figuring out that they're trying to do, which isn't apparent on the outside. So Puro in a nutshell.
That makes sense. Santana, if I did not fully address the question, please feel free to reach out to Dr. Brooks directly too. I think we have in the chat. Thanks for utilizing the chat, everybody. Really helpful. I appreciate it. So the next question is from Megan. Thinking about comorbidities, is there a way to determine which symptom to address first, or would OCD symptoms need to be addressed first before, say, PTSD? I know we kind of touched this on the anxiety side. Just wanted to ask Megan's full question.
Yeah. So if PTSD, oh gosh, that's a tough one. That's a really tough one. I think it would be case dependent. One example was, recently working with somebody who has BDD, and the BDD began occurring before a traumatic event, a sexual assault. But the individual came to me for the symptoms of BDD, the intrusive thoughts about physical appearance. And BDD operates very similar as OCD. But the PTSD symptoms were actually much more intrusive and much more invasive. And so we ended up doing CPT to address the PTSD. Oh my gosh, all of these acronyms. And through the CPT process, the person actually acquired some of those skills that are really important to use with ERP. So I guess it's really case dependent, but if you're going through, like TFCBT for a kiddo or CPT for an adolescent or a young adult, they're going to learn some of the same skills and some of the same strategies that they would in ERP, but certainly addressing the most problematic disorder first.
Thank you. That was the last of the questions, and we are right at time. So thank you, Dr. Christina Brooks. Thank you so much for this wonderful presentation, answering all of these great, challenging questions. I really appreciate everybody's engagement, involvement. If you guys want to, in the chat, provide any feedback for Dr. Brooks, I will share them with her when I share the recording with her. If you want to share those pie recipes with me, I will distribute them to everybody else along with the recording. But if I do not speak to you or see any of you before, have a happy Thanksgiving, a wonderful holiday season. We're getting to the cold months, so everybody take care, stay well, and I look forward to seeing you all on a future Lunch and Learn.
Thank you.
Take care.